So I'm going to talk to you today about the spectrum of human papillomavirus infection, and I tried to think of some kind of dynamic title, but the best I could come up with was the benign to the deadly, which certainly is the case for HPV. I've got no conflicts of interest to disclose. So as most of you in the audience will know, there's more than 100 types of human papillomavirus which can infect human epithelium or mucosa. They are classified into high-risk types, which are the ones that cause cancer or potentially cause cancer, and low-risk types. HPV-16, which is one of the high-risk types, causes most cases of anal, and in fact probably all cases of cervical cancer. And HPV-6 and 11 are the low-risk types that cause most cases of anogenital warts. So starting off with warts, the benign, which were the bane of my life when I was doing sexual health training 20 years ago. Edward will probably remember those horrible clinics where we basically thought we're training to be specialists and we're spending 4 hours burning wart after wart after wart after patient after patient after patient. And nowadays, when my registrars come to me and say, I've got a young girl downstairs who I think's got warts, I'm actually saying to her, are you sure? Because the impact of the HPV vaccination has been so impressive on the occurrence of genital warts, and I'll cover that in a second. So again, we all know transmission by sexual contact. Rarely they can be transmitted from mother to baby, and subclinical transmission when there's no warts actually visible is very common. The incubation period from the time that someone acquires the wart virus to, low-risk wart virus to developing warts is usually 2 to 4 months. So that meant that warts themselves were a really great endpoint for showing the early impact of the vaccination, of Gardasil, which is the quadrivalent vaccination we're using in Australia and many other countries are using. To assess the early impact of that after it was introduced. So we've done pretty well in terms of vaccine coverage in Australia. You can see that by far and away the best bang for your buck is when you vaccinate the kids at school, with almost round about, say, 3/4 of girls vaccinated between the beginning of the vaccination program in 2007 and 2015, getting all 3 doses of the vaccination. And what we saw was a rapid decline in genital warts. Remember, as I said, incubation periods within six months. The dotted line here is when we introduced the school-based program plus a catch-up program for women up to the age of 26. And this is the proportion of Australian women presenting to sexual health clinics at their first visit with genital warts. And we saw this happen up to 2011, over a 90% reduction in first visits for genital warts in women, youngest age group, and then almost a 75% reduction in the 21 to 30-year age group. So that was hugely impressive. And then the other thing that we saw substantial herd protection in heterosexual men. So by herd protection, I mean if you're having sex with someone who doesn't have the virus because they've been vaccinated, then you're not going to catch the virus. So that's herd protection. And in the heterosexual men, in the youngest age group, there was over an 80% reduction in that time period from the women being vaccinated. The men weren't vaccinated until 2013. And in the 21 to 30 age group, over 50% reduction. But clearly, the same protection wasn't afforded of gay men because they weren't having sex with a vaccinated heterosexual women. And this just shows in the blue line the proportion of homosexual men presenting with anogenital warts in that same time period, and there was no significant difference. Another good news story is with Indigenous Australians, and there was a lot of work put into this because of the well-known health disparities between non-Indigenous and Indigenous Australians. And the vaccination impact was also seen amongst Aboriginal women, as well as the same herd protection amongst their male counterparts. So in these three tables here, you can see the under 21s, the 21s to 30s, the over 30 years. So the blue is the Indigenous, huge drops in Indigenous, huge drops in the slightly older age groups as well, but no drop in either the Indigenous or non-Indigenous populations in the unvaccinated women, which is what you would expect. So in terms of the epidemiology of warts, this is from our national sex survey, which the second one was carried out in 2012-2013. They're very common. Hopefully that's going to be something of the past in decades to come, with over 3% of men reporting a lifetime history, over 4% of women reporting a lifetime history, and almost 6% of gay men reporting a lifetime history of anal warts. And some of the risk factors that we've looked at, we did the Health in Men study a few years ago in Sydney, and it was a cohort study which followed 1,500 gay men for 3 years, and we tested them every year for HIV and all the other STIs, and they did interviews regarding their sexual behaviour. And we found that genital warts were independently associated with younger age and more frequent anal fingering, but anal warts, also younger age, but also other manual sexual practices such as fingering and fisting. And interestingly, when we threw that all into the mix, neither anal warts or genital warts in gay men were actually independently reported to associated with condomless anal sex, suggesting that they're actually commonly transmitted by fingers. And indeed, there have been some studies published showing with PCR testing under the fingernails that you can recover genital HPV types from under the fingernails of sexually active adults. In pregnancy, this is one of the few horrible pictures that I've got to show you. The good thing is that there's been no link shown between warts and adverse pregnancy outcomes. But the problem for us as clinicians is that often you get a massive explosion of the size of the warts due to hormonal changes during pregnancy. And most treatments, aside from just freezing them, are contraindicated in pregnancy. So the goal is often just to minimize the bulk of genital warts, because clearly if they get too big and obstruct the birth canal, the woman's going to have a cesarean section, and we want to try and avoid that. So we're generally seeing these women more frequently to just reduce the bulk of the warts to allow them to have hopefully a normal vaginal delivery. I said the benign, but the benign is not always benign. And again, this is data from the Health in Men study of gay men in Sydney. And when we looked at the risk factors for HIV transmission, and we basically controlled for all of the unprotected anal sexual practices that might transmit HIV, the only two STIs that were significantly and independently associated with acquiring HIV were anal warts and a history of, and anal gonorrhea as well. So that's of concern, but perhaps not so much so relevant nowadays, in that we've got so many other HIV prevention interventions available. The other benign issue that can be problematic is when the infection is passed on from the mother to her baby during birth, and that's called recurrent respiratory papillomatosis, or RRP. And the vast majority is due to the same types that cause the majority of anogenital warts, but it's the reverse pattern to genital warts. So usually they're caused by HPV-6 rather than HPV-11, but HPV-11 actually causes most RRP. Although it's rare, expectant mothers who have genital warts are often very anxious, as they are passing on anything or harming their baby in any way. And RRP usually requires repeated surgical treatments. It's associated with high morbidity and the occasional death. And there's two types. Young children develop it, and called juvenile onset RRP, and there's also adult onset. And the highest risk, and I guess this is most relevant for the clinicians in the room, is young women who have active genital warts who have a vaginal delivery at term. So again, HPV vaccination should have a significant impact on that. In terms of the juvenile onset RRP, the median age that that's develops is 4 years. It's the most common benign neoplasm of the larynx and the second most common cause of childhood hoarseness. Unfortunately, in about a third of kids, it spreads to the trachea and the bronchi, and there is a significant risk of respiratory obstruction. My colleagues in Melbourne looked at Australia-wide what the prevalence was of RRP, and as I said, it is very rare. There was only 30 to 60 cases of RRP identified per year under 20-year-olds, which is an incidence of about 1 per 100,000 of that age group. and the highest rate was in children between 5 to 9 years, where the incidence was roughly twice that. And that's in keeping with international data. So that's from the benign to the kind of benign, and now we'll move on to the deadly, or potentially deadly. So human papillomavirus is a common cause of cancer, and in terms of the league table, along with Helicobacter pylori, which causes stomach and gastric lymphoma and stomach cancer, and Hep B and Hep C causing liver cancer, it causes about 5% of all cancers worldwide. Should I be pointing this somewhere else? I don't seem to. Do I just point it anywhere? Okay. And this is the number of global cancer cases from the most common to the least common attributed to HPV by the site. So as you can see, cancers of the cervix uteri all are attributed to that. Cancers of the anus, almost 90% are attributed to HPV. Vaginal cancers, almost 80%. And then you drop down to about 50% of penile cancers, around about a third of oropharyngeal cancers, and about a quarter of vulval cancers. But if you look at all of those sites, over 50%, over half of all the cancers at all of those sites are caused by human papillomavirus and the high-risk types of human papillomavirus. And this has particular relevance for you in New Zealand, because Edward was telling me earlier that you've adopted the nonavalent vaccine, which is shown in this last column here, whereas we're still using the quadrivalent vaccine in Australia and in many other countries. So what you can see is the additional bang for your buck that you're getting, because the relative contribution of HPV 16 and 18, which is in the bi or the quadrivalent vaccine, it will prevent about 70% of cervical cancers. But when you're looking at the nonavalent vaccine, which you're giving, you're actually getting an extra 20% protection, almost 90% protection against cervical cancer. So that's fantastic. You get slightly less bang for your buck for anal cancers, because the majority of anal cancers are caused by HPV 16. So the contribution of HPV 16 and 18 causes almost 90%, and you're really only getting an extra few percentage points of protection against anal cancer. So really it's great news to hear that your government has funded nonavalent vaccine, and so not only are you going to beat us in the prevention of cancer states, we know you beat us in rugby all the time, but enough said about that. Okay, I thought I'd say a bit about oropharyngeal cancers. I know it's not really something we talk about in sexual health clinics, but you know, a third of them are caused by HPV. And really just, this is data from the US from the last 30 years up to the mid-noughties. And the key things I just want to point out, this is HPV-related in males and unrelated in males, HPV-related cancers in females, and HPV-related unrelated cancers in females. So the two key things I want to point out are that HPV-related cancers are much higher in males than in females over the last 30 years. And that the relative contribution of non-HPV-related cancers is dropping off significantly, while the contribution of HPV-related cancers is increasing, especially in the younger age groups. So in terms of those that are HPV-related in the oropharynx, 60% are caused by HPV 16, and risk factors are sexual. They include more oral and vaginal sexual partners at younger age, but it's actually a good prognostic factor to have an HPV-related cancer versus a non-HPV-related cancer, because if you're HPV 16 positive, you actually have better improved overall and disease-free survival from your cancer. And also HPV positive cancers are more responsive to chemo and radiation therapy than HPV negative cancers. But malignant transformation in the oropharynx is due to be much more likely to just persistent high-risk HPV. Unfortunately, there's no screening programs proven or currently recommended, but again, we hope vaccinations will have a big impact on that. But why is the increased incidence of HPV-associated cancer more common in young people? Well, we don't really know the answer for that. It could be that they're having more sexual partners or oral sex at a younger age. It could be less smoking in younger cohorts. And also, the other question that we don't really know the answers to is, why are the rates higher in men? It could be differences in sexual behavior. It could be biological differences, that men are less likely to clear high-risk HPV from the pharynx. It could be that there's higher HPV prevalence in cervical versus penile tissues, or even higher viral load of HPV, which means that men are more likely to catch high-risk HPV via oral sex than women. So I know that you guys are renewing your cervical screening program next year, and we were meant to have ours done at the beginning of this year, but the government very cleverly gave the role and the money to Telstra, who are our major telephone company, rather than giving it to people who actually knew what they were doing. So surprise, surprise, it was delayed for almost a year, and we're hoping that it's going to start in December this year. Okay, sorry. So this was the last policy for National Cervical Screening Programme. What we did was we had 2 yearly pap tests from 18 to 69 years, a registry reminder, and this is the introduction of that National Screening Programme, and we saw a significant decline in cancers, reduced cancers by about 50%. But the participation wasn't great. The recommended 2 yearly participation wasn't even 60%. And even within 5 years, there was still almost 20% of women who hadn't had a pap test. So why are we renewing it? Well, there's new knowledge on the development of cervical cancer, new evidence for prevention and screening, new technologies such as liquid-based cytology rather than the old pap test on the slide, computer-assisted image analysis, so it can be automated and done on the ThinPrep analyzer as a mass screening, HPV tests, and also, of course, importantly, the introduction of National HPV Programme, which in Australia was introduced for all girls in 2007 and all boys in 2013 at school. And this just shows you the cost effectiveness, and I'll not really talk too much about this except to say that current practice is up here in unvaccinated and vaccinated, and with genotyping as the primary screening test shown in the orange filled-in circles, you're actually getting a much better effectiveness of the screening program, so it's more cost-effective. And it costs less compared with the current screening program. So when you're looking at it here, you're talking about roughly $380 discounted lifetime cost, and your average will be about $260 with the primary HPV testing. And again, you get a similar but even more substantial drop in those who are vaccinated with primary HPV testing as the cervical screening program. So what we're going to be doing is partial genotyping. We're going to be doing an HPV test and testing for types 16 and 18. If it's positive for either of those types, that will then reflex, so it means an automatic liquid-based cytology or ThinPrep sample will be assessed. There'll be a 5-year screening interval, start at 25 years, exit at 70 to 74 years. All sexually active women who are vaccinated or not. The new addition is that we will be offering self-collection of vaginal specimens for those women who have never screened or are under-screened, because that's possible with HPV testing. And there'll be a national register sent to remind women when they're due for screening. And this is just some data from Europe, just looking at the benefits of cytology versus, benefits I should say, of HPV screening versus cytology. So this is following women for a 6-year period, and this is the incidence of the highest grade of precancer or invasive cervical cancer over that time period. And what you can see is that you had about 100 per 10,000 women who screened negative here at baseline who would have developed high-grade precancer or cancer by the end of the 6 years, but that would only be about 25 or 30 with primary HPV testing, and a slight additional benefit with cytology negative testing as well. And as I said, that's what will be happening in our screening program, because they'll be testing for HPV, and if they're negative, they will then go on and if they're positive, they'll then go on and have cytology as well. So people have questioned, is it safe to start screening and not start screening until 25 years of age? Well, this has been published in the Medical Journal of Australia, 3 years at average incidence, which is very, very low amongst the youngest age group that we were previously screening. And 25 years of screening women below this age has had absolutely no impact on cervical cancer in this age group, which, as I said, is rare anyway. A systematic literature review found no evidence for screening. As I mentioned, very low incidence in cervical cancer in these women, and which is expected to decline further because of the vaccination program. And International Agency for Research on Cancer do recommend not screening women under the age of 25. Sorry. Okay, and the other question is it safe to extend the screening interval to 5 yearly? Well, I guess these two, this was pooled data, and the endpoint was actually cancer, so it was invasive cervical cancer, from 4 European trials involving almost 180,000 women. And you can see that the benefit of primary HPV testing when they were negative at test entry is really very powerful, right up to 8 years since the baseline negative test. So you're only getting an incidence of around 15 or 20 per 100,000 women, whereas cytology, you're getting an incidence of at least twice that. And you know, looking at the time, at 2 years here, it's similar, but out to 5 years, you're actually getting a much greater reduction in prevention of cervical cancer, which is what it's all about. So this is our cervical screening pathway. I won't really go into this, you can look it up online, but as I said, HPV is either detected or not detected. They'll get the liquid-based cytology or thin prep, and then depending on that result, they'll either be referred directly for a colposcopy or asked for a repeat test, and again, tested for HPV and liquid-based cytology or not. And 80% of cervical cancer in Australia currently occurs in women who have never screened or have been underscreened. So that's basically the reason behind why we are recommending self-collection as an alternative for women who are underscreened or never screened. It's not as effective as a health professional collected sample, but it's still much more effective than the current PAP test. The accuracy varies for different tests, obviously, and it's less cost effective than the routine pathway. And the other problem is, of course, that the test that will be done by the clinician will be a thin prep test on which they can test the HPV type, and then they can automatically send that for liquid-based cytology to see if they have any abnormal cells. With this home-based testing, they won't have that specimen, so they'll then, if they get a high-risk HPV type, then need to visit a clinician for a cytology sample to be sent for testing. So primary HPV screening is estimated will lead up to 30% fewer cases of cervical cancer and fewer deaths from cervical cancer. So the main changes from this December in Australia is we've gone from the PAP test to the HPV test, 2 yearly to 5 yearly. We're starting at a later age, we're ending slightly later, and we're doing more in terms of trying to encourage women to attend and also offering self-collection for people that haven't tested or are significantly underscreened. Just a bit more about the quadrivalent vaccine Gardasil. This is basically results from immediately before it was introduced in 2007, and that's in the blue bars, to immediately after it was introduced in 2009. And this was the prevalence of cervical HPV, and these are the high-risk types. These 4 types are in Gardasil, and these additional high-risk types are in the nonavalent vaccine that you're using. So what you can see was a huge reduction in all of the quadrivalent types, which is what was on offer in Australia. And also there was some cross-protection seen with other high-risk types, and you did get some reduction in those as well. But you should be seeing a much greater decline with your nonavalent vaccine and a much greater protective effect, which is fantastic news. I just wanted to mention that vaccination is prophylactic, so it prevents infection. It's not therapeutic. It doesn't treat infection. There has been studies that have been looked at the randomized trials of HPV vaccination. And when they looked at that, actually giving a dose of HPV vaccination was associated with a reduced risk of recurrence of high-grade precancerous lesions in women after treatment, but that was actually related to other types of high-risk HPV. It wasn't related to the type of HPV that actually gave them the high-risk precancerous lesion that was treated in the first place. So it wasn't related to reducing the recurrence of the initial infection that had led to their cervical precancer. So, moving on to the back end of things, anal cancer. So anal cancer is on the increase in Australia. And what I should point out here is it's actually higher in women than it is in men. And I'll come to the reasons for that in a second. It not only has anal cancer been increasing in Australia, it's increasing in every single country in which the incidence has been measured. And for HIV positive men, where infection-related cancers were really a major cause of death back in the day, antiretroviral therapy and suppressing the viral load has made absolutely no difference to the incidence of anal cancer. And so anal cancer is now the most common non-AIDS defining cancer in people living with HIV. Some more horrible pictures. I'm afraid I've had the not such a pleasure of seeing some of these kind of cases in clinical practice. So why is this important? It's a really disgustingly horrible disease. It's degrading for the patient. It causes significant morbidity and mortality, only a 60 to 70% 5-year survival if it's not caught early, and very unpleasant treatment, which involves cutting out big, huge portions of the anal canal and perianal area and combined chemoradiation therapy. So cancers caused by viruses are impacted by immunity. And this is why there's several populations who are at increased risk of anal cancer. Now, one part of this conundrum is anal HPV exposure, and that's why women are so much higher risk, because the vagina and female genitalia is in such close proximity to the anus in women, and HPV disease and cervical disease is so much more common in women than it is compared with penile disease in men, then you can actually quite easily get spread of these high-risk HPV types to the anal canal, and that's why women are at so much higher risk than men in the general population. But also through sexual practices, anal HPV exposure, some women will have receptive anal sex, but gay and bisexual men will far more commonly have receptive anal sex. Risk is also increased in those who are immunosuppressed or who have dysfunctional immune systems, including those organ transplant recipients and those living with HIV. We've made huge steps in improving HIV treatments in the last 25 years, but the immune system still doesn't work quite as well as someone who is HIV negative. So that's why HIV positive men are still at much higher risk of HPV-related cancers. And when those two combine, you get the highest risk group, which is gay and bisexual men who are living with HIV. And this is kind of like a traffic light, I guess, system of those. In the general population, anal cancer is a very, very rare cancer. It's about 1 to 2 per 100,000 of the general population. But when you look at women who have had previous HPV disease, the risk is 5 to 20-fold higher. Organ transplant recipients, 5 to 10 times higher. HIV negative gay men, 5 to 20 times higher. HIV positive people, not including gay and bisexual men, 10 times higher. But if you look at HIV positive gay and bisexual men, the relative risk is about 50. And to put this in context, the annual incidence of up to 130 is the same as the incidence of prostate cancer and bowel cancer in the general population, which are two of the most common cancers. So why have gay men got such high risks of cancer, anal cancer, compared with and high-risk HPV compared with women? Well, we did this study a few years ago, and it's basically all explained by sexual behavior. This first graph shows you the percentage of gay men and heterosexual women with more than one recent sexual partner. So this is heterosexual women. So you can see under 5% of them after the age of 30 report more than one recent sexual partner, whereas in all the groups of gay men, over 50% are reporting more than one recent sexual partner. And that then explains why this was American women and worldwide women, that the HPV prevalence in the anus is so low in women as you get older, but the prevalence is maintained very high, above 50% in gay men. So it's basically all due to sexual behaviors. So what does an anal cancer diagnostic service look like? Well, this is what it currently looks like. Sticking a finger up a bum. And Jason Ong in Melbourne did his PhD on this. And basically his PhD was doing digital anal rectal examinations to detect, for early detection of anal cancers in HIV positive gay and bisexual men who, as I said, were the highest risk groups. So he questioned many sexual health and HIV physicians, and 86% of them thought it was very important to screen for, but none were actually doing it in a systematic way, and 22% were doing digital anal rectal examinations in a very ad hoc manner. From the participants' perspective, and there was over 300 men who were in this study, 100% said they felt in control, 82% felt relaxed, 100% said their general health and anal health were the same or better, and there was no change in quality of life during the screening process. There was no increase in cancer worry, there was very low reports of pain and anal bleeding after the procedure, and most importantly, almost all were willing to have another anal examination with the finger in a year's time, which is what's currently recommended. It also is likely to be cost effective in older HIV positive gay men who are at highest risk, just as long as you know what you're feeling. Because if you can often feel masses, you can feel fleshy warts, you can feel hemorrhoids, you can feel other benign outgrowths of the anal canal when you're doing a digital anal examination. And so then if you're referring all them on for further investigations, it makes it a lot less cost effective. But I can tell you, for those clinicians in the audience who are doing this, you really know when you're detecting an anal cancer. I mean, it feels hard, it feels craggy, it feels nasty. I guess the main concern is detecting the ones that are very superficial and very early, because they can just present often as just a mild thickening, and they're the ones that really do need referred for further investigation and biopsy. So I'm not going to say much about the study for the prevention of anal cancer, but as Edward said, we're very proud of our acronym because it is anal cancer and we're spanking it out the field, I think. But I just thought I'd say why we're doing an observational study of HSIL, which is the high-grade precancerous lesions. Well, as I mentioned earlier, it's highly prevalent. Around 30% to up to a half of HIV positive men have a precancerous anal lesion. Progression to cancer is much less common than in the cervix, which is kind of lucky, because with those kind of rates of high-grade precancerous lesion, we would have people dropping like flies. And we know from the dubious New Zealand study that progression from high-grade lesions to cancer in the cervix is 1 in 80 per year. It's about five-fold less than that, we estimate, in positive gay men, and about 50-fold less than that in HIV-negative gay men. And that was estimated from a systematic review we did a few years ago. And the other problem is that treating precancerous lesions in the cervix is relatively straightforward. You can use laser, you can use loop excision, you can entirely remove that whole transformation zone where the cancers will develop. But treatment of anal cancer is not standard of care. Treatment is really difficult. A Cochrane review showed no proof of effectiveness. Recurrence rates are about 50% at 1 year, and very high rates of very severe side effects, from 20 to 40% report very severe side effects following treatment. And treatment also may be potentially lethal. I don't know if you saw this. A poor Japanese woman who was having cervical laser treatment farted and set herself alight last year. So obviously we want to avoid any kind of mishaps like that when we're treating anal cancer. So this is the study and design of our study. It's a 3-year natural history study. Gay and bisexual men aged 35 years and over, both positive and negative. We have detailed behavioural interviews, we do cytology, HPV testing, high-resolution anoscopy, which is akin to colposcopy, which is used to investigate female cervical high-grade lesions, and we do biopsy of any suspicious lesions at each visit over 3 years. And we enrolled over 600 participants by August 2015, so we'll be finishing up by August next year. There are very close similarities between the anal and the cervix. The area where the precancerous lesions and cancers develop is called the squamocolumnar junction, and you have that in the bum as well as in the cervix. And that's why we've adopted very similar screening procedures. So we're using the same instrument as we use for colposcopy, but we call it an anoscope because we're looking at the bum. We use anoscopes rather than speculums, and we use acetic acid and iodine to identify lesions that potentially are high-grade lesions. And I don't know if you can see because of the lights, but there's an acetyl white lesion there, which didn't take up the second dye, and I biopsied that, and that was the highest grade AIM3 precancerous lesion. This one here at the end, very thick and very nasty looking, and that was all high-grade lesion as well. And Gardasil, the quadrivalent vaccine, has been shown to be effective against AIN overall, but I should point out not individually significantly effective against the high-risk HPV types or indeed against HPV-6. And that was because this study was only enrolled men up to the age of 26. So although HPV infection itself will be common in gay men up to that age, the disease process which then leads to anal intraepithelial neoplasia will not be common. And that's why there was such small numbers, and therefore we didn't show, or I'm saying we, it wasn't my study, they didn't manage to show a huge effect. But we do expect, as that group of men who have been vaccinated grow older, that we'll begin to see a massive impact on the incidence of anal cancer. The other thing I just wanted to point out was the types, this was HPV-16, which I said causes most anal cancers. We looked at seroincidence, so this was on serology and developing antibodies to HPV-16 in the HIM cohort of gay men. And what you can see is the incidence actually didn't fall off until after the age of 35. So from that data, that suggests to us that HPV vaccination might actually have good efficacy in gay and bisexual men up to the age of age 35. And in fact, in gay male patients coming in to see me, my advice is it's not going to do you any harm, it can only do you benefit, so if you're willing to pay the money, then go and get yourself vaccinated. So just that's me finished. So in conclusion, high-risk HPV is one of the most common causes of cancer globally, and we hope and expect that HPV vaccination will have a huge impact on these cancers in future generations. Anogenital warts are common, but thankfully due to the vaccines becoming far less so, they are often recurrent and troublesome, and they do increase the risk of HIV acquisition, but as I said, in the setting of all the other tools we have to prevent HIV nowadays, I don't think that's such a concern. And as clinicians, we can reassure mothers who have active genital warts who are pregnant that transmission to their baby is extremely rare. HPV oropharyngeal cancers are increasing, while the smoking alcohol-related cancers in the oropharynx are becoming less common, and men are disproportionately affected by those HPV-related cancers. Unfortunately, no screening tests, but again, the vaccination hopefully will provide good protection. In Australia, our new cervical screening program will prevent more women from getting cervical cancer with less frequent screening and a higher cost effectiveness. And anal cancer is really a huge and increasing problem, especially amongst women and gay and bisexual men, especially those living with HIV. I'll be presenting an update of SPANC tomorrow afternoon, so I'd be delighted for you to come along and hear that. But for now, our clinical practice should be an annual finger up the bum in HIV-positive gay men, at least in those over the age of 40 or 50, and anyone in those risk groups who presents with anal symptoms. So I'd just like to acknowledge my boss and mentor, Andrew Gulick, Jason Ong and Marianne Saville for use of some of their slides, and the huge SPANC research team who I work with. And thank you all for your attention.